morning, everyone. My name is. Shall we begin with an opening prayer? Our Lord and Master, we thank you for today. We thank you for how far you brought us. We begin this presentation in the name of the Father, the Son, and the Holy Spirit. Amen. Once again, my name is Prince Amon-Kotey, and I'm presenting on Hirschsprung's disease. So Hirschsprung's disease is a developmental disorder of the intrinsic components of the enteric nervous system. It's characterized by the absence of ganglion cells in the myenteric and submucosal plexuses of the distal intestine. It is also called the congenital aganglionosis or aganglionic megacolon. The aganglionic segment of the bowel fails to relax in these patients, and it causes a functional intestinal obstruction. Until the beginning of the 20th century, most children with congenital megacolon died. They mainly died from malnutrition and enterocolitis. In resource-poor countries, Hirschsprung's disease still remains a significant burden on neonatal morbidity and mortality, since the cases are usually presented late. The children with failure to thrive in a setting, malnutrition and abdominal distension, are normally treated with herbal concoctions, usually in the form of NMS. A little history about Hirschsprung's disease. In 1691, Frederick Reich was the first to describe Hirschsprung's disease in a 5-year-old child who was dying from intestinal obstruction. In 1800, another account of Hirschsprung's disease was given by Battini, and it was described as a congenital megacolon. Harold Hirschsprung, who has inherited the name, was a pathologist in Germany, Copenhagen. In 1886, he described the disease in 2 infants at a conference in Berlin. However, he presented the dilated colon as a diseased part of the pathology. In 1896, Treves did the first left colectomy with the excision of the rectum in a 6-year-old. She is apparently still alive. In 1901, Tittel was the first to describe the absence of ganglion cells in the distal colon in a child with Hirschsprung's disease. The first successful treatment came in 1936 by Swenson, and he's been credited with the put-through name as Swenson's put-through. In 1949, Swenson again published a paper recommending rectal sigmoidectomy with preservation of the anal sphincters as the optimal treatment of this disease. Originally performed without a decompression colostomy, however, he adopted to a multi-stage approach with colostomy as the initial step due to technical challenges. Whitehouse and Kenohan described aganglionosis of the distal intestine as a cause of intestinal obstruction in their patients. That was in 1948 and 1949. The incidence of Hirschsprung's is 1 in 5,000 live births, according to up-to-date. Male to female ratio 4:1 in short segments, 2:1 in long segments, and the ratio seems to be decreasing with more extensive aganglionosis. It approaches 1:1 for total colonic aganglionosis. And there is a familiar clustering for non-syndromic Hirschsprungs, with an overall recurrence risk of approximately 3% in siblings for short segment disease, or up to 17% if the proband has a long segment disease. Genetically, is a complex disorder which is caused by variants in multiple rare genes with low penetrance and variable expression. The pathophysiology can be defined embryologically and genetically. Embryologically, the enteric nervous system is organized into 2 main plexuses: the myenteric ibex plexus, which is localized in between the inner circular and outer longitudinal layer of the intestines, and then the submucosal plexus, which is localized within the mucosal layer of the intestine. They arise from neural crest cells. Embryologically, the neural crest cells migrate crinocaudally to colonize the gut. It begins by the 5th week, and by the 12th week of gestation to 13 weeks, there should have been complete colonization of the intestines by enteric ganglion cells. The most accepted theory in crinocaudal the most accepted theory as the process to which Hirschsprung's disease results is a defect in crinocaudal migration of the neural crest cells, which fails to reach the distal intestine, rendering that segment aganglionic. The second possibility is that the neural crest cells reach the destination, but they fail to survive or differentiate into the ganglion cells due to a hostile microenvironment. Hirschsprung's disease is, so the genetic pathophysiology has been said to be a complex disorder caused by variants in multiple red genes with low penetrance and variable expression. Again, the mutations in several genes have been identified in patients with Hirschsprung's disease. The individuals with the multiple pathogenic variants have substantially increased risk compared to those with fewer pathogenic variants. However, for non-syndromic forms, the long segment disease tends to follow autosomal dominant inheritance pattern, and their short segment diseases often reflects autosomal recessive or multifactorial inheritance. The predominant gene affected in Hirschsprung's disease is the Rett proto-oncogene. A second major gene identified is the endothelin receptor B type B gene. Other variants in other genes have been described, EDN3, etc. We'll talk a little about the Rett. So Rett is an acronym for rearranged during transfection. It's a proto-oncogene. It's located on chromosome 10q11.2. It codes for a protein called receptor tyrosine kinase. There's a transmembrane tyrosine kinase receptor. The ligand that binds to it to activate this is the GDNF, which is the glial cell line derived neurotrophic factor. When it binds to the co-receptor of this receptor, which is the receptor tyrosine kinase, it activates it, just like all tyrosine kinase receptors. Dimerization transduces signals downstream, which leads to the neural crest cells growth, proliferation, their survival, migration, and differentiation into enteric ganglia. Has been proven in a mouse model. Pathogenic mutations in the red gene subsequently results in loss of intestinal motor function because of the aganglionosis. More than 20 different mutations have been identified in Rett and described. In one study, Rett variants were identified in 82% of patients with total colonic aganglionosis and 33% of patients with short segment disease. Most Hirschsprung's disease are linked to Rett mutations, even without an identified coding sequence mutation. Second gene of significance is the EDRNB, which is the endothelin receptor type B. It's located on chromosome 13 q22.3. It codes for a G protein coupled receptor, which is expressed on the surface of the neural crest cells as well. The ligand that binds to it is endothelin 3. So the ligand receptor complex transduces signals downstream, which again leads to the migration and development of the neural crest cells and differentiation into the enteric ganglion cells at the level of the intestines. EDNRB mutation causes the Varenberg syndrome type 4, and 100% of patients with this pathology have Hirschsprung's disease. The genetic mechanism underlying the strong association between Down syndrome and Hirschsprung's disease have not really been established. Multiple mechanisms have been associated to this correlation. Again, Rett variants have been identified, but there's also documentation of variants in the Down syndrome cell adhesion model, which is located on chromosome 21. Down syndrome is present in 2 to 16% of individuals with Hirschsprung's disease, according to UpToDate. And conversely, Hirschsprung's disease occurs in less than 1% of individuals with Down syndrome, although the overall risk of Hirschsprung's disease in Down syndrome is much higher than in the general population. Hirschsprung's disease can be classified as syndromic or non-syndromic, depending on whether the patient has other syndromic features with the Hirschsprung's. Notable syndromes are the Down syndrome and the other neurocristopathies. Varenberg syndrome is also associated with the Smith-Lemli-Opitz syndrome, the Undyne skills, etc. Okay. Classification can also be based on the length of the aganglionic segments. Short segments Hirschsprung's disease represents majority of cases, 75%. It involves the rectum with or without the sigmoid. Long segment Hirschsprung's disease is called long segment when the level of the aganglionosis is proximal to the sigmoid colon. Total colonic aganglionosis involves the entire colon, And total intestinal aganglionosis, it involves the small intestines as well. Ultra short segments, only a few cm above the anal canal, is involved. The classification can also be based on anatomical location of where the aganglionosis segment is. So rectosigmoid again is the classic presentation. It represents about 80%, left-sided, which ascends up to the descending colon, and then pancolonic, small intestine involvement. So this is an image demonstrating that. There are several congenital anomalies which have been associated to Hirschsprung's disease. Approximately 20 to 25% of patients with Hirschsprung's have associated congenital anomalies. Genitourinary anomalies of the kidneys and then the urinary tracts has been identified in most patients with Hirschsprung's. The pathology is usually hydronephrosis, renal hypoplasia. They also present with visual and hearing impairments. Actually, in a case series conducted, ophthalmology abnormalities were found in approximately 40% of patients with Hirschsprung's disease. Most of them were refractive errors, hyperopia, astigmatism, or myopia. Visual impairment was also present in 9.4% of the patients. Hearing impairment was also found in 5% of the individuals with Hirschsprung's disease, which is 3 times higher than the general population. Another congenital anomaly is congenital heart diseases, which is usually seen in the syndromic Hirschsprungs, especially those with Down syndrome. Approximately 5% of those without any syndrome also had congenital heart disease. Some patients also had anorectal malformation. So this is a distribution of the frequencies of congenital anomalies in Hirschsprung's. They usually have a short segment Hirschsprung's disease. The most frequent congenital anomaly is the ophthalmologic abnormalities, followed by the congenital heart diseases, and then the congenital anomaly of the kidneys and the urinary tracts. Differential diagnosis of Hirschsprung's is meconium plaque syndrome, malrotation with volvulus, some intestinal stenosis, ileal atresia. And then there are also pathologies that present, they have signs and symptoms similar to Hirschsprung's disease, but when we do the rectal biopsy, they have ganglion within the intestines. So they are described as variants of Hirschsprung's disease. Some are the intestinal neuronal dysplasias, hypoganglionosis, internal anal sphincter achalasia, and desmosis coli. Diagnosis of Hirschsprung's disease. So again, your clinical assessment, take a history. They may present in the neonatal stage usually. They may come as infants or adolescents or adults. And then your physical examination, and then your investigation. So that's a picture of a child with Hirschsprung's disease. You can see the obvious abdominal distension and peristalsis. Okay. So in neonates, they usually present, the presentation is that of delayed passage of meconium, usually more than 48 hours of life. Ideally, 100% of normal full-term neonates should have passed meconium by 48 hours of life. 45 to 90% of infants with Hirschsprung's disease will not pass meconium within the first 48 hours of life. Because it's not 100%, then early passage of meconium does not rule out Hirschsprung's disease. They come with abdominal distension, vomiting, usually bilous, feeding intolerance, failure to thrive in severe cases. On examination, they have general signs of sepsis. They are irritable, febrile, they are crying. They have signs of enterocolitis, also may precede the sepsis, or may precede the sepsis, sorry. They come with distended hypertympanic abdomen. You may see the visible peristalsis. You do a DR, your rectum is empty. When you remove your digates, explosive stool passes out. It's called the blast or the squirt sign, and usually associated with mild relief of the abdominal distension. The infantile stages, they also come with chronic refractory constipation with or without frequent abdominal distension. Again, there may be signs of failure to thrive, poor weight gain, delayed growth. Depending on how they present, they might present with enterocolitis, again, fever, abdominal distension, explosive diarrhea, vomiting episodes. Some of them might also be, there may be a history of dependence on NMS with significant encopresis. Encopresis is when they are passing to someone you expect to be having normal, well-developed bowel habits. Is passing stools at awkward places like in their pants or maybe on the floor. Um, their stools are ribbon like. On examination, again, the distended hypertympanic abdomen, visible peristalsis, rectum empty, but then passage of stools, you may have the blood signs. In adolescents, they are usually stable because for them to progress to the adolescent stage, it might be a short segment, a ganglionic segment. Um, so they rarely present complicated with serious complications. There's usually a lifelong history of chronic constipation. They also might have abdominal distension, but they are usually stable. Again, they might have other signs of the comorbidities, like congenital cardiac anomalies, etc. Diagnostic investigations for Hirschsprungs after you've taken your history and physical examination includes your contrast enema, anorectal manometry, and then rectal biopsy. So the contrast enema is usually a 24-hour post evacuation. We want some stool in the bowel before we do the contrast enema. It helps well alienate the transition zone as well as the dilated proximal bowel. The contrast of choice is a water-soluble contrast. If you can get urographene rather than the barium, we advise it. We prefer the contrast, water-soluble contrast, because you might be dealing with the meconium ileus or meconium plaque, and water-soluble contrasts are usually hyperosmolar, so they absorb a lot of fluid and they can lead to dislodging. They can literally dissolve and dislodge the meconium plaque. So it could be therapeutic. Your contrast enema could be therapeutic. Again, because it's water-soluble, if there's an unrecognized bowel perforation and you cause peritonitis, you can easily mop them up with little complications as compared to barium enema, which can cause really bad peritonitis, abscess, etc. When we do the contrast enema, we are interested in two phases, the filling phase and then the evacuation phase. Filling phase, as we are pumping the contrast, we are seeing the delineation of the bowel. So you can see the distended bowel during the filling phase. You can tell the narrow distal segments, okay, the filling phase. You can also be able to tell the transition zone. We are also interested in two findings. The transition zone, which is the narrowed, so you see the narrow distal bowel with dilated proximal bowel. In children with rectosigmoid disease, the transition zone is best viewed in the lateral view. Also, the absence of a transition zone does not rule out Hirschsprung's disease, as 10% of patients do not demonstrate a transition zone. Rectosigmoid ratio is also one of the parameters we are interested in. Ideally, the rectum should be of, because it's usually the place where the stool is pooling, is slightly wider in diameter than the sigmoid. But that's not the case for Hirschsprung's disease. So you have a ratio less than 1, which is suggestive of Hirschsprung's disease. The views presented might be AP and lateral views. Lateral is best to view the transition zone. As you can see in these images, the AP view and the lateral view, you can clearly see the transition zone of the lateral view, which is on your left. Okay. In addition to the filling phase, the evacuation phase, we are interested in the retention of the contrast. It's highly suggestive of Hirschsprung's disease. It's done, ideally you should do the plain radiograph 24 hours post-evacuation to check whether the contrast you infiltrated is still retained. And it will help in making a suggestion of Hirschsprung's disease. Anorectal manometry is sometimes used to complement barium enema. I'm yet to see one in our setting. It's a test of the recto-anal inhibitory reflex. So ideally, when the rectum is filling up, there's a reflex relaxation of the internal anal sphincter. It's normal in children, but it is absent in children with Hirschsprung's disease. For anorectal manometry, the whole point is that a catheter is inserted. Let's see. Yeah, so you insert a catheter into the rectum, you inflate it to create the distension of the rectum and then the impression of filling of the rectum. And then you'll be, with the aid of the sensor, documenting the relaxation or contraction. This guy, the tone of the internal anal sphincter. Now, this technique is more reliable from day 12 after birth, when the normal rectoanal rectoenteric reflex is present. It's not specific for Hirschsprungs. And manometry could be followed by a rectal biopsy when the rectal inner inhibitory reflex is abnormal. So again, in other children, it's easier to do, but you can have a false positive because um, the internal anal sphincter might be relaxing alright, but the external anal sphincter may be contracting, and it will mask the relaxation response. Is the most useful in evaluation of an older child, however, with chronic constipation, where documentation of a normal rectal inner inhibitory reflex effectively rules out a Hirschsprung's disease and avoids the need for a rectal biopsy. Rectal biopsy is the gold standard for diagnosing Hirschsprung's disease. There are two modalities of taking the biopsy. You can do a full thickness biopsy and sample both the Meissner's and then the Albach's plexuses, or you can do a superficial by the bedside using just a suction. And then you just sample some mucosa and some mucosa tissues. They contain just the Meissner's plexus, and then you send them for histopathology. Again, to take the sample, you have to go at least 1.5 cm above the dentist line, because there's a paucity of ganglion cells in normal individuals around 0.5 to 1 cm above the dentist line. So you might not get much ganglion cells. It might not mean that the patient is having Hirschsprung's disease. Again, if you go too proximally, you might miss the aganglionic segment. Histological findings which are diagnostic of Hirschsprung's is the first is absent ganglion cells in the submucosa and anterior plexus, which is what is reported in our setting. Hypertrophy of again, I have to indicate that because the commonest biopsy we take is the suction or the superficial rectal biopsy, you can easily take a segment where, so ideally when there's differentiation, the differentiation starts at the level of the Albach's plexus, and then the theory is 2 to 3 days later they migrate deep into the submucosa plexus, and then they differentiate into the submucosa, where they differentiate into the Meissner's plexus. So if you go and take the mucosa and submucosa at a level where there's yet to be migration or there's incomplete migration, you might mistakenly diagnose the patient of Hirschsprung's disease when they do not have Hirschsprung's disease. And another parameter is hypertrophy of the nerve bundles or trunks. Again, you can see this with the hematoxylin and eosin staining, but technically, to diagnose hypertrophy, you might have to measure the bundles, which we don't do. Again, increased activity of acetylcholinesterase. There's a special stain for acetylcholinesterase, which we usually do not do in addition to our H&E staining. Absent carotenoid is the most specific of all these parameters. However, this parameter is identified on immunohistochemistry studies, which is also not part of what we do here. So the question is, are positives always positives or not? Other investigations you may do is your BE creatinine. Again, if they come in with diarrhea, you're interested in your electrolytes, full blood counts. If you're thinking of enterocolitis, Hirschsprung-associated enterocolitis, you might have elevated OBVC, relative neutrophilia. You might do genetics testing in developed countries to consider if syndromic presentations or familial history. Complications of Hirschsprung's, just to list a few. I have the Hirschsprung-associated enterocolitis, which is the most severe of all the complications and the most life-threatening. They might come with intestinal obstruction. They might come with bowel perforation, usually cecal perforation or appendiceal perforations, because of the dilated bowel, which is contracting against the competent ileocecal valve usually. They might come in septic, malnutrition, failure to thrive, and they might come with volvulus. We'll talk a little about Hayek. So it's a serious and potentially life-threatening inflammation of the lining mucosa, colonic lining mucosa. Approximately 10% of children with Hirschsprung's disease present with abdominal distension, fever, foul smelling, diarrhea, vomiting, and lethargy, which is due to Hayek. The clinical presentation may be chronic, so they might have recurrent abdominal distensions, which may resolve intermittently, failure to thrive, and intermittent diarrhea, constipation. Or they might come in a really acute phase, life-threatening, with signs of bowel perforation, sepsis, and then shock. This particular complication can occur before or even after surgical intervention. The etiology is controversial, but I mean the theory is there's bowel stasis, so bacterial overgrowth in aganglionic bowel. Causative organisms indicated rotavirus or Clostridium difficile. Again, because of the overgrowth of bacteria, you alter the microbiome. There's said to be impaired the defense of the intestinal mucosa, mainly because of the loss of the secretory activity of the mucosa, because you are losing your, they don't have the Meissner's plexus, and therefore they have low levels of IgA, they have low levels of mucin. Ischemia and pressure injury in the dilated proximal bowel said to lead to transmural inflammation and risk of perforation. I mean, this is the discussion, but it's controversial. The management, again, you take your history and physical examination. Because Hirschsprung's disease is generally associated with constipation, when they come with the diarrhea, it might be a little bit confusing to make the diagnosis. But you have to take a careful history and pick up, especially the history of failure to pass meconium or delayed passage of meconium, and then the presence of intermittent obstructive episodes. So they have episodes of that constipation. This will hint to a possible Hirschsprung's disease. Diagnosis is purely clinical for Hirschsprung associated enterocolitis, and investigations are merely supportive. So when you do your full blood count, you're interested in WBC elevation and then the left shifts of neutrophilia, elevated CRP for inflammation, B creatinine because of the possible electrolytes derangements. X-rays, not really your go-to, but when you do them, you pick up the dilated loose of bowel with multiple fluid levels, and then the signs of colitis, which is the sawtooth mucosal irregularity. You pick up the cutoff sign and rectal sigmoid with absence of distal. You might also pick up intestinal nematosis. Management. The first and most important is resuscitation, IV fluids, electrolytes correction. You're also interested in decompressing the bowel. Pass an NG tube. You do a DRE. If you confirm the explosive diarrhea, do your, again, with or without that, you do your rectal irrigations. Also extremely important. You need to decompress the bowel as soon as possible. You do your saline washouts. Start your broad spectrum antibiotics. Metronidazole for the anaerobes too. Bowel rest, keep neoperos in moderate to severe cases. And you can be doing some trophic feeding, but basically you keep neoperos. You monitor the patient for shock or perforation. Again, if your bowel decompression is not achieving results, the best is to go in and do your stoma. It's also part of the resuscitation. Management of Hirschsprung's disease. Management usually starts preoperatively. So again, depending on how the patient comes in, they might need resuscitation. You do your broad spectrum antibiotics, your bowel decompression, either with the NG tube, your rectal washouts, colonic lavage with the rectal tube, and again, still there's room for emergency stoma if need be. Once the patient has been resuscitated and stabilized, you can do the operation semi-electively. Associated congenital anomalies can also be further evaluated, like a cardiac disease or those with the congenital central hypoventilation syndrome, which is the Ondines. You investigate and then you manage them and prepare them properly before the definitive surgical repair. Whilst you are waiting, most patients, we discharge them home on breast milk, or especially when the bowel decompression is adequate and they are clinically stable on it. You can also be doing elemental formula in combination with rectal stimulations or irrigation. So the irrigations is the most important in Hirschsprung's disease management on OPD basis. You teach the parents or caregivers the appropriate technique while a full workup is being performed. Consider diversion stomas for patients who cannot be maintained on the full enteral diet, because we want to optimize the nutrition whilst receiving 2 to 3 times daily irrigations. So this might hint to a longer segmented ganglionic colon. Patients who tolerate the fees and remain decompressed with irrigation, and you work them up for the primary pull-through operation. In older children with an extremely dilated colon, again, you want to delay the pull-through. Again, they will benefit from a stoma. You want to allow time for at least the redundant colon tissues to undergo atrophy. for to help with your anastomosis. So the definitive surgical management is your put through. There are different procedures or techniques available. We have the Swenson's procedure, Duhamel's procedure, the Suave's or Suave's procedure. Some of them are outdated, which is the Rubin and the States. There are minimal access approaches to, like the laparoscopic put through. You can do the transanal perineal put through. Sorry, ultra short sphincterotomy, short extended myomectomy, and then the total colonic ganglionosis. So there's the chimera, and then there's the Martin's procedures, etc. Okay. We'll discuss a little bit about some of the techniques. Swenson's technique is the original one which was being done. So this is the original put-through operation for Hirschsprung's disease. Basically, you have an aganglionic segment, so we just go in and resect the aganglionic segment. We do a laparotomy to assess the colon, mobilize the colon, and then you basically laparotomy and then the perineal approach. You remove the aganglionic rectum completely. You pull down the ganglionic colon, and then you do an end-to-end colloidal anastomosis. Again, laparotomy is usually required, but the challenge is in freeing the rectum and in dividing the rectum, you would have to dissect very, very important pelvic structures which are closely adhered to the rectum. So you have to stay really, really close to the rectal wall. You cannot just injure the rectal vessels and then the nerves, but you can also injure structures, especially anteriorly, the seminal vesicles, prostates in males, even the ureters, in females, the vagina. So the dissection is really, really meticulously done, and it's not easy to do. Again, there's always the risk of, with this particular procedure, the risk of anastomotic leak, pelvic abscesses is really presents early, and it happens really quickly in this technique. Also because, especially when you do it as a one-stage procedure, and the bowel is still passing through your anastomosis, there's always the risk of a breakdown. So there's also the advice, there's also room for a colostomy to bypass the stools whilst you allow for the healing. And the Suave's procedure. So this particular procedure was designed to avoid the risk of injury to the pelvic structures associated with dissecting or freeing the rectum. So basically what happens is you do an endodermal dissection and mucosect. So you identify your distal segments, and then transanally you make an incision through the mucosa. The depth of the incision should not go beyond the muscularis externa, and then you peel off the mucosa off the bed, which is the muscularis externa. So you are peeling off the mucosa, submucosa proximally along the length of the ganglionic segments. After that, you go and advance the ganglionic segments, which is proximal. You advance them and pull them down, and then you anastomose it to the so you do your colloidal anastomosis. We'll talk a little bit more about. So with this one, you don't breach the wall of the rectum. Therefore, you don't encounter pelvic structures. That's one. Another thing too is you are literally pulling down the ganglionic segment through a cuff of aganglionic tissues or aganglionic segment of bowel. So there's that likelihood of chronic constipation. So they have issues with constipation a lot because of what looks like a constriction at the base, at the end of the intestine. But we'll talk more about the disadvantages and advantages as we move on. Then the Duhamel. So Duhamel was developed in 1956. So basically with this one, you divide the bowel at the proximal length, at the proximal end of your ganglionic segment, and then you form a pouch. So we have so this is supposed to be your distal bowel, and this is the proximal bowel which has been pulled down. So basically this is where the division initially took place. It was at this level that we divided, and then we closed the distal end to form a pouch, sort of. But this whole bowel is an aganglionic bowel. we are not resecting it. You just form a pouch with it. This one is ganglionic and is a normal bowel. So ideally, instead of resecting this one, you form a pouch here too. You close this end too, and then you pull this one down through the least vascular plane, which is posterior, which is retrorectal, in between the sacrum and then the rectum. And then you do a side-to-side anastomosis. So the stool will come from this side, and then it will be emptied into what looks like a reservoir over here before it's expelled. The advantage of this one is relatively simpler to do. There's less dissections available, less dissections done, and also because you are going through an avascular plane, you really do not damage the pelvic perirectal tissues, especially those anterolateral. Um, Once again, because you are having a big reservoir over there which is collecting stool in an aganglionic bowel which is not peristaltic, there's always the risk of fecal stones from fecal impactions at that site, and they can actually be so big that they might block the opening over here. So this opening is done by making an incision in the posterior wall of the aganglionic bowel and then the anterior wall of the ganglionic bowel. Okay. Right, so just a summary of the various techniques. So for the swabs, again, the advantage is you are preserving the outer muscular calf of the rectum. There's a reduced risk of pelvic nerve injury because you don't breach the mucosa, the muscularis externa, even to get to the external. And then there's a lower risk of fecal incontinence compared to Swenson. There's good cosmetic outcome. No abdominal stoma is required. But because of the retained muscular calf, you may cause obstructive symptoms later, and it's technically demanding, and there's always the risk of calf strictures and abscesses. For Swenson's, we are removing the aganglionic segments completely, including the rectum, and then a direct colloidal anastomosis, so there's no retained calf. Long-term results can be excellent if the pelvic nerves are well preserved, but there's a higher risk of pelvic nerve injury. They might come in with urinary or sexual dysfunction later. There's also the risk of anastomotic leak and strictures. Technically, it is really challenging because of the dissection in the deep pelvis. The Duhamel's procedure, you are avoiding deep pelvic dissection. It's also relatively safer for pelvic nerves. And because you are creating a wide rectal reservoir, it reduces obstructive symptoms, and it's technically easier than the Swenson's. But the disadvantage is you retain a large part of the aganglionic rectum, and then there's the risk of fecal stasis and enterocolitis, and they may cause persistent constipation too. And there's the laparoscopic pull-through. So this one, laparoscopically, you mobilize the rectum below the peritoneal reflection, and then the short mucosa dissection is done through a perineal approach. The rectum is then prolapsed through the anus, and then the anastomosis is done from below. I don't know if you get a picture, but this procedure has been associated with shorter hospital time. Both early and midterm results appear to be equivalent to those reported for the open procedures. Laparoscopic approaches have been also described for the Duhamel's and Swenson's operations as well, with excellent short-term results reported. And there's the purely transanal pull-through, so there's no laparoscopy involved. So if that one, you make a mucosa incision about 0.5 to 1 cm above the dentate line. Again, the mucosa is stripped of the underlying muscle as you do in the Swiss procedure. The rectal muscle is then incised circumferentially, and then the dissection is again continued on the rectal wall. So this one, you breach the rectal wall. You divide the vessels as they enter the rectum, and then the entire rectum and part of the sigmoid colon is delivered through the anus. When the transition zone is reached, the anastomosis is done from below. In patients with more proximal transition zone, which is usually above the proximal sigmoid colon, you might need a laparoscopy to help mobilize the left or the descending colon, as well as the splenic flexure. A transanal approach has been shown to have low complication risk, and they require minimal analgesia, and is associated with early feeding and then the discharge. So what's the role of colostomy in management of Hirschsprungs? Many children with Hirschsprung's disease present late, especially in assessing, malnourished, and then a dilated colon. So a colostomy may actually be a life-saving procedure. One-stage operations is becoming popular, as documented because of its safety and approach, and then there's also the argument that you avoid morbidities with the stomachs in infants, as well as the cost involved. But it's important to remember that it's in the stomachs are indicated for children, especially those with severe enterocolitis, those who come with perforation or signs of perforation, those who are malnourished because you need your albumin for your anastomosis to heal well. And massive dilated proximal bowel. Again, there's high risk of anastomotic breakdown if the discrepancies in diameters between the colon and then the anus is too large. Situations where there is inadequate pathology to support, pathology support to reliably identify the transition zone on frozen sections too. You might want to do a colostomy because they are not very sure. Post-operative management of Hirschsprung's disease patients after the definitive surgery. So for laparoscopic or transanal put-through, most of them can be discharged within 24 to 48 hours. The anastomosis should be calibrated with an appropriately sized dilator or finger 1 to 2 weeks after the procedure. Some surgeons instruct that the patient dilates the anastomosis on a daily basis. However, it's been found to be unnecessary in most cases. Instead, you should just be performing weekly calibration over a period of 4 to 6 weeks. There are some common long-term outcomes with post-op. They might still have obstructive symptoms. They might still come with the vomiting, abdominal distension, bloating, severe constipation, which may persist long after the definitive surgery. Pathologies associated with it are, it could be a mechanical obstruction, depending on the type of the technique you used. There could be recurrent or residual ganglionosis. They may actually have an additional motility disorder involving the ganglionated bowel. Again, there could be an internal anal sphincter achalasia. There could be a functional megacolon where they are it's just a stool holding behavior. The patients might also come complaining of soiling following the surgery. And the possible causes are abnormal sensation. They are unable to feel the rectal distension and also loss of transitional epithelium. Again, abnormal sphincter function, which is referred to as the pseudo-incontinence, is associated with severe constipation, also with hyperperistalsis of the pull-through bowel. So in summary, Hirschsprung's disease is a neurocrystopathy. It's associated with absence of ganglion cells in the distal rectum and extends proximally, into the colon of variable length. The genetic predisposition is caused by variants in multiple regions with low penetrance and variable expression. The predominant gene affected is the Rett proto-oncogene. Male to female ratio is 4:1. Most commonly associated syndrome in the syndromic Hirschsprung's is trisomy 21. For all patients with Hirschsprung's, and particularly those with syndromic Hirschsprung's, genitourinary anomalies, hearing impairment, and visual impairments are common. Majority of patients with Hirschsprung's disease are diagnosed in the neonatal period, and HIAC is the most serious complication of Hirschsprung's. The gold standard of diagnosis is rectal biopsy, and definitive management is surgical. These are my references. Thank you. Any questions, please?
Good morning. Well done for this extensive presentation. Please, the management that you have put here is tailored towards the short segment Hirschsprung disease. I want to know in the case of total colon or total intestinal disease, what will be the definitive treatment? And then the other question will be the role of nutrition in children with this pathology.
Okay, thank you.
Oh, I was looking for the pen. All right. Uh, First of all, I must say it's a very good presentation. Thank you, Prince, for doing justice to the topic. This is a very important topic. We may say it's a problem for pediatric surgeons, but if you become an adult surgeon, you may encounter Hirschsprungs. I have a histology of a 75-year-old man who is a father of a doctor with me now, and it's difficult the way forward for him because he's 75. He's got some comorbidities and and the colorectal surgeons are not ready to operate on him. So he's now doing mechanical and chemical decompression of his bowel. So I want to emphasize that even though Hirschsprung is a problem for pediatric surgeons, you may become a general surgeon and you are likely to encounter. I will come to comments about the presentation, but to answer the question you asked about long segment Hirschsprungs, and then you also mentioned total intestinal ganglionosis. For long segment, the main modality, surgical modality, is Duhamel. Okay? Because you want to, the function of the colon is basically for absorption of water. Okay? And then you have some bacteria bacteria that should give you vitamin K and also for pH regulation. So in long segment or total colonic ganglionosis, you don't want to get rid of the whole colon. So you need a certain amount of colon, and Duhamel will give you that. What he described, you bring a ganglionated bowel and you leave a ganglionated bowel, and they will have the walls, anterior wall, posterior wall, and you want to communicate the anterior wall and the posterior wall. Okay, so you have an aganglionic colon that will do the absorption and pH and all the rest for you. I hope you understand that. You appreciate that. Okay, so Duhamel will give you that, and there are modifications of Duhamel. Martin is the main one. It's basically what you use to create the common channel between them. We use a stapler. That's the whole idea of Duhamel's modification. Martin's modification of Duhamel. Okay, all right. The amount of aganglionic colon you leave behind, as he said, you leave a too long aganglionic bowel as a reservoir. It can fill up with feces and even collapse on the anterior ganglionated bowel. And we've been getting some of them from people who don't regularly do Hirschsprung surgery. So Duhamel is the main thing for total colonic aganglionosis. For intestinal aganglionosis, to be honest, they are very rare. They are not common. And if you have it, is likely not to be compatible with life. Okay, I have seen only one from Takwa, and my boss, Dr. Glover, who is now the main guy who has been around for ages, he said he's seen about 2. Okay, the one we had from Takwa, the child did not make it. Okay, elsewhere they have attempted to do intestinal transplant, but that comes with a lot of challenges. So they put a child on total parenteral nutrition. Then of age, they will look for either cadaveric or a live human intestine, and then they transplant. The success rate is not high. I hope I've answered your questions. If they are further, I can. Oh yeah, so that's why total colonic ganglionosis is the whole colon. So from rectum all the way to cecum. That is the definition of total colonic ganglionosis. The definition for long segment is up to the splenic flexure. Okay, and then the short segment, which is the commonest, about 75–80%, is the sigmoid and the rectum, rectosigmoid. Okay, so that's the anatomic classification. So total colonic ganglionosis is all the way to the cecum. If you have to do that, then your ganglionated bowel is the terminal ileum. Okay, so imagine you anastomose terminal ileum to the inner region. Of course, you are going to have intestinal hurry. Transit time will be very short, isn't it? And with ileal content, there is still some digestive enzymes. So if you do that, you see the children, the inner region is all excoriated from the digestive enzymes. Okay, and then you are not going to have absorption, so malnutrition and all that. That is why you need a bit of aganglonic colon for Duhamel. Okay, so that will aid absorption and then reduce the transit time and all the rest of it. But there's a guy in Boston Children's Hospital. He swears that Duhamel doesn't work, and he's been doing pull-through with ileum. Okay, and he thinks that with time, you know, children, they really adapt. With time, he's able to manage the inner excoriation. He gives them something to reduce the enzymatic activity of the content and all that. So some people are doing ileal pull-through without a colonic segment. If there are no further questions, I think there's a lot to be said regarding the topic, and we may not have enough time to discuss. But if you were to go into the definition, if you can show the slide on definition. Sorry, yes. So this is important definition, but there are few things that must be captured in this definition. When it comes to pediatric surgery, you know, a lot of things you have to qualify the definition with congenital. Okay, so I'll prefer you say it's a congenital developmental disorder. You are born with it. If you leave it as a developmental disorder, it's like you are born and then after birth and all that. But this is really congenital. Okay, and part of the definition here you say intrinsic component. Okay, that's fine, but basically it's failure of formation of the enteric nervous system. Okay, failure of formation of the enteric nervous system. So the two theories, whether it's failure of migration or the hostile environment, at the end of the day, you don't form the enteric nervous system properly. And the enteric nervous system will basically control the muscular and then the secretory function of the GI. Okay, so the muscular is just the peristaltic aspect, but the secretory function, which, because you need your nerve control of even blood supply to the GI, and then the immunology of the GI, they are all under the influence of the enteric nervous system. So both the muscular and secretory functions are impaired in Hirschsprung disease. That is why they are at risk of what? Hirschsprung's associated enterocolitis, because the immunity is also impaired. Mucin, IgA, and other immunological factors. Okay, so that will predispose them to Hirschsprung's associated enterocolitis. So it's not just about the stasis, because people can walk around for days without moving their bowel. They have stasis, but they will not develop enterocolitis. Okay, so that is important. Now, in terms of presentation, if you go again, you go to presentation. We will come to the pathophysiology, but presentation. I was interested in why you brought differential diagnosis before clinical presentation, because you need to get the presentation first, make your diagnosis, and then you think of what else could mimic or can mimic Hirschsprung disease. I hope you get my point. So you don't bring differential diagnosis before clinical presentation. The clinical presentation for neonatal period is also important to point out that they can come with peritonitis. Okay, and peritonitis will be as a result of, you mentioned, cecal perforation. So you may have a child who gets to you just with peritonitis, okay, and you may go in and there's no transition zone because they've not established enough stasis for you to get the ganglionated bowel dilating and narrowing or funneling into the aganglionic. I hope that is clear. So if you have a child maybe at the district level and you open and you get a cecal perforation, it's easy to close that perforation, isn't it? Or you do a stoma. But don't forget to do what? A rectal biopsy, because that is what will clinch the diagnosis for you. Otherwise, you do the ileostomy or you close the perforation. Later, you go and reverse the ileostomy. And because you have not made the diagnosis, the child will come back with what? Recurrent constipation. But if you do rectal biopsy, then that will clinch the diagnosis for you and that will change management. I don't know, the last mortality meeting, we had a child like that, and I think it was presented here, and we lost that child because we missed the opportunity to take a rectal biopsy at the first surgery. Okay, so that is very important. And then with this imaging, there's a role of plain X-ray, because if you do plain X-ray with peritonitis, of course you get the pneumoperitoneum and the rest of it. So when it comes to investigation, I think you should add, like in an exam or essay, okay, if you should make mention of what? Plain, the role of plain abdominal X-ray before enema. Now, I said I'll come to the pathophysiology, but whilst I'm at the investigation, let's mention, you said for imaging the enema, you prefer water-soluble contrast, isn't it? But that is with certain situations. In the neonatal period, you prefer water-soluble gastrography than a barium, for the simple reason that if your differential diagnosis of meconium plaque, if you use a water-soluble, you are likely to get relief of the plaque, okay? So that becomes both what? Therapeutic and what? Investigative. Again, for a neonatal period, if you use that water-soluble contrast and there is risk of peritonitis. You will not get a barium, because barium peritonitis can be very dangerous, because if it's not water soluble, it will just sit in the peritoneum and then cause third spacing and all the rest of it. So water soluble for neonatal period, very important. Water soluble also in the event of Hirschsprung associated enterocolitis. When you have Hirschsprung associated enterocolitis, there's risk of what? Perforation. So if you go and use barium as a contrast study and there's perforation, then it will be on you. So that's very important. But otherwise, barium is the contrast of choice because of the cost and how easy it is to get it. What else did I want to say? You mentioned manometry, that you haven't cited it here before. Of course, I've also not seen it before. But in literature, there's a reason why it's becoming outdated. Okay, Swenson used to use it as diagnostic choice, okay, for Hirschsprung disease. But over the period, of course, people have done studies. Remember, if you want to do anal manometry in a child, the child may not cooperate with you, isn't it? You may have to sedate. Once you sedate, and you need conscious level for the rectoanal inhibitory reflex, isn't it? So if you sedate, it may obviate the study, the findings for you. Again, he mentioned it. For preterm, okay, you can't use anal manometry until the child is about 39 weeks post-conception. And even for a term neonate, the rectoanal inhibitory reflex is not fully established until day 12. Okay, so inhibitory or manometry is no longer in vogue. People are not using it. But if you go to centers where they study constipation in particular, okay, because there are so many other conditions that can mimic Hirschsprung disease, so they need this anal manometry for diagnosing other conditions. There's a condition called internal anal achalasia, okay, which may be like a differential for ultra short Hirschsprung disease. But you may do biopsy and it's normal, but the patient just has a strong tone of the internal sphincter. So they do some of these manometric studies to rule out such conditions. So you don't use it for what? Hirschsprung disease, but in centers where they study constipation extensively, is one of the armaments for study. The biopsy, the differentiation is important, whether it's superficial or full thickness. But I heard you saying that we do superficial here. Is that what you said? In terms of biopsy. The superficial? No. We do full thickness. That's the gold standard, okay? Because full thickness will give you both submucosa, which is the Messner's, and then the myenteric, which is the ABA, okay? Because in the pathophysiology, and that will be my last comment when I come to pathophysiology. In the pathophysiology, the migration of the neural crest cells is aboral, okay? So they enter the myenteric, populate it before they go to the submucosa, okay? So if you stick to superficial biopsies, like he said, you may not find ganglia cells in the submucosa, but the ganglia cells may be in the myenteric plexus. So full thickness will give you advantage of studying both submucosa and the myenteric plexuses. I hope we are clear on that. And here we do full thickness. The disadvantage with full thickness is you need anesthesia. Okay, you can't do it under local or bedside. But superficial biopsy can be done as a bedside procedure. So outside, they do a lot of superficial. And they increase their yield, their sensitivity, by not just looking for ganglia cells. They are able to do all the other things, acetylcholinesterase. They are able to do creatinine. So it gives them a higher sensitivity. Okay, so that's the advantage and disadvantage with both. But we do full thickness biopsy here. In doing the full thickness under anesthesia, of course, but you have to bear in mind what level will you take the biopsy. You said that 1.5 cm above the dentate line, we all have a region of physiologic aganglionosis, okay? But we are able to overcome it because of Valsalva maneuver during defecation, okay? So it's like physiologically we are all Hirschsprungs. I hope you get it. So when you are taking a biopsy, you have to go above that 1.52 cm, okay? But you also have to be careful that you don't go too far above, because if you have ultra short, then you may miss that segment. I hope that is clear. All right. That should not be the last comment. I will come to management. The management, you mentioned the 3 classical surgical procedures. Swenson is the first one. He first did rectal sigmoidectomy to get rid of the ganglionic bowel, okay? And then Suave because of the complications of Swenson, and then Duhamel. But transanal pull-through is a minimal access for all these 3. We have to understand that, okay? Because in the past, they were doing the resection transabdominally, especially with Swenson's. They were doing dissection, as he said, pelvic dissection. And remember, Hirschsprung is a disease in terms of gender. It affects male more than what? Females. Ratio of 4:1. So they were doing a lot of pelvic dissections and damaging the nerves that will give you erection. You understand? So he followed them up, then into their reproductive years, they were not getting erection. So Suave then came in that, no, I don't want to do a lot of what? Pelvic dissection. I will do endorectal dissection. So I'll make incision, then I will stay within the lumen. But he's been leaving a lot of calf, rectal calf, okay, with the pull-through, and that has been causing constipation, okay? Then Duhamel found a way of trying to bring the ganglionated bowel behind the aganglionated bowel, perirectal, avoiding the nervi erigentis. Okay, all these 3 were being done by way of laparotomy. Then somebody devised minimally invasive transanal pull-through. So you retract the dentate, okay, with what we call a Lone Star. Then with Swenson, which is what we do here, you measure about 1.5 centimeters above the dentate line. Because if you tamper with the dentate line, the patient will not have sensation. And it's one of the complications of swelling. Okay? Patient will not have sensation. So you would have damaged their sensation. So you go about 1.5, 2 cm above the dentate. Then you make full resection of the rectum. Then you resect all the aganglionic bowel to the point of ganglionated bowel. Okay? Then you anastomose coloanal. How do you know that you have resected all the aganglionated bowel? Ideally, you should have frozen section in theater, so that at the point of anastomosis, you would have given tissue to pathologists to report that yes, the bowel you are anastomosing is what? Ganglionated, and it will function. Here we don't have it. So what do? What's our guide here? Friends, you were with us. What's our guide?
So
Our
can you
guide
use,
is there?
the diatemy when you touch it, then the muzzle contract.
No. We use the barium study. Okay? You should have a transition zone in mind. Okay? So when you have done your barium study and you see a transition zone, you go at least about 10 centimeters above what? Transition zone. That's where you reflect. And then you pray and hope that the pathologist will report that the proximal end of the resected specimen is what? Ganglionated. Are we clear? So if it's not ganglionated, or clinically your patient keeps coming back with constipation, it's likely that you have left what? An aganglionic colon. Are we clear? So that is what we do here. Luckily, with experience and the very experienced hands at the unit, we are able to get away with these things because we don't have frozen sessions. So your barium study is very important. Before you do any Hirschsprung surgery, you should have that image, especially with transition zone. And then you know that, oh, maybe the transition zone is what? Descending colon. Therefore, if I go 10 cm above it, I'm likely to pull through a ganglionated bowel and overcome the constipation. Are we clear? Okay, so that's fine.
I'm guessing you don't do it early then, because as you said earlier, there are times where you can't see the transition zone. So in that case, what do you do?
Especially for neonates. Neonatal period, if you were to do barium enema, you may not see transition zone. Okay, and if you also do their pull through early, you have these challenges with Hirschsprung associated enterocolitis. Number one, because of their age, they are not able to generate enough vasava to even overcome the physiologic aganglionosis. So they will always have a bit of what? Stasis. And with stasis and incomplete resection of aganglionosis and all that, they will give you troubles with Hirschsprung associated enterocolitis. The earliest we have done in our unit is, I think, about 3 months or 2 months. Okay, and then you monitor them. So you do the pull through anyway, then you monitor them. The diagnosis for them on the barium study is retention of contrast, 24-hour film. So they come constipated, you do washout, you decompress them, okay? Then you discharge them after teaching the parents how to administer the washout. Then when they come, you do your barium study. You may not see transition zone, but at least they will have enough retention of contrast post 24-hour evacuation. So that will guide you what to do, okay? And because the commonest type is rectosigmoid, you go resect rectosigmoid, isn't it? You pull through maybe descending, and you send the specimen for what? Histopathology. They may report that the proximal end is what? Ganglionated. You've had it, you've done it. I hope that answers your question. But for the older children, we get away with it because we get the transition zone. When you have to send a patient for barium study, there are certain things you must do. Number one, or you must not do. You must or must not do. Prince, if you give a request to somebody to do barium study, I think your time is almost up, isn't it? You shouldn't do digital rectal examination, okay? You shouldn't do washout, at least for 72 hours. The whole idea is you want to establish the Hirschsprung disease, the stasis, okay? So that the distal bowel will be collapsed, isn't it? Proximal bowel will be dilated, funneling into the distal bowel. So it will help the study, the yield of the study. Because if you decompress them, then you may not get the transition zone outlined on the barium study. I hope. So these are some of the practical things you have to know. the management, back to the surgical or management, it's important to add, maybe for you going forward, a time will come, all these surgeries will be useless. Why? Because there is tissue engineering, stem cell transplant, where cells are being introduced into the aganglionic bowel, helping the cells to populate, helping the cells to differentiate and become what? Ganglia cells. Okay, the Germans are leading it. So a time will come, if you become a pediatric surgeon, you may not have a child to operate on. That will be good, isn't it? So it's important to know that going forward, because you are future surgeons. And that is important. I want to end with the pathophysiology. It's important to understand the pathophysiology of Hirschsprung disease. Okay? In the past, they say, oh, failure of migration of what? Neural crest cells. It's no longer the basis. The migration may occur. They will migrate all right. By the 4th week, 5th week of gestation, neural crest cells appear in the esophagus. By the 5th week, they are in the midgut. Okay, 5th, 7th week, they are in the midgut. By the 12th week, they are in the colon. When they are there, first of all, the environment must also be conducive. So you have the mesodermal environment of the bowel. You mentioned some genes, red gene, isn't it? It's a transmembrane gene expressed on the neural crest cells. But the ligand is what? Yes, glycine-derived neurotrophic factor. And that is from the mesoderm of the bowel itself. Okay? So the bowel itself may not be expressing this GDNF. Okay? And therefore you can't blame the what? The ganglia cells or the neural crest cells. The mesoderm itself must produce the ligand. The second gene, which is totally emphasized, is the endothelin receptor gene. Okay, again, the ligand is what? Endothelin 3. That is also expressed from the mesoderm. So they virtually become like the chemotactic factors for the migrating neural crest cells. So the cells may be migrating. Again, when they migrate, they get to destination. They should multiply, because maybe 10 cells are migrating, isn't it? But they should multiply and become enough ganglia cells for the motor and sensory functions. So that proliferation signaling is both by this GDF and red gene interaction, and then endothelin and the endothelin factor receptor. I hope I'm clear on that. The difference between these two genetic mechanics, whether it's GDNF and red gene on one hand, and the endothelin and endothelin receptor on the other hand, they will all promote migration. They will all promote proliferation. But differentiation, the endothelin factor will not allow the cells to differentiate. They must be in their progenitor state. Because once you differentiate, you cannot move on. I hope that is clear. So it has to maintain a progenitor state that can go on and migrate to the distal end. The red gene will switch off after 12 weeks. And that is why Hirschsprung disease is commoner in the distal colon. Because if they switch on before, they switch off before they get to the distal colon, then they cannot interact with GDNF, isn't it? Proliferate, differentiate. So that pathophysiology is what is now feeding into the understanding of Hirschsprung disease. And I think you have to look at the genetics. You've really done well with this, but there are so many genes. These are the master genes, but there are so many genes that are interacting with this to affect development of the enteric nervous system. Thank you very much. If there's any question, you can ask. Oh, Nutrition, yes, very important. He mentioned one of the presentations is what? Failure to thrive, isn't it? Sometimes just the mere distension, they will not be able to eat, or early satiety and all that. So they come malnourished. So when they come, and usually we do colostomy. And I must emphasize the management of choice for Hirschsprung-associated enterocolitis should actually be colostomy. But here we get away with the so-called gentle rectal washout, isn't it? Because theater space and all that. And if you do washout and they get decompression, then, or they get decompressed, then fine, you can plan for elective surgery. But ideally, we have to colostomize them. Once you give them colostomy and you do high protein, high caloric diet, which definition is sometimes a bit ambiguous, they recover very well. Those with us on the ward, there's a 12-year-old, what's his name, Christopher, you know, the first bird. He came in a very bad state. I thought we were going to lose. I think I did it with you. Rahim, were you part of it, or you took? Okay. So once you colostomize, you decompress them, they start feeding, absorption is good. They really get their nutrition back, and sometimes they get a catch-up of growth and all the rest. A question before I put down the microphone. What's the difference between a washout and enema?
So, thank you. Nice presentation, Doc. Between the conservative management and definitive, how do you, like, what kinds of food do you advise such that at least would help them? I don't know how to put it. The main issue is constipation. Is there food types, let's say in infant, childhood, is there any food types you can advise to help them at least reduce the frequency of the constipation while awaiting definitive surgery?
Don't eat this, don't eat that. I know they are constipating diet, isn't it? Especially some of these toddlers, maybe all they want to eat is Indomie. And you know Indomie can be constipating and all the rest. But we don't ban them from eating those food types. They can eat anything they want. The whole idea about Hirschsprung's is it's a functional constipation. You understand? So it doesn't matter what they eat. If they will obstruct, they will obstruct. So the main thing is decompression. Decompression by washout, whether chemical or mechanical. Okay. So you do the washout to decompress them. And you are doing that because you don't want them to get Hirschsprung's associated enterocolitis. The so-called aganglionic megacolon, as if it's a megacolon that is disease, is wrong. Okay, actually it's the megacolon that is normal. It's the collapsed distal colon that is disease. It doesn't have ganglia cells, therefore there's no peristalsis, and it's at constant tone, and the proximal bowel is working against it. That's why it becomes so big, isn't it, and hypertrophied. Okay, so the toxic megacolon is not the disease, it's actually the distal, but it becomes toxic because you be hoarding feces, isn't it, and then putrefaction, then transmural migration of the bacteria causing the enterocolitis. So in fact, Hirschsprung-associated enterocolitis, the problem with the proximal bowel, like he said, you see this gobblestone appearance of the proximal bowel, sawtooth appearance. You can lose the whole proximal bowel, And that is the bowel you are going to use for your pull through. And that is why people advocate colostomy straight away, so that the transmural enterocolitis will not affect your normal bowel. I hope that is clear. All right. So food, they can eat anything. My question of difference between enema and washout. So the main thing is, I don't know to say which one is active and which one is passive. We say? Yes. So you are using a solution, whatever it is, whether soap with water, saline, whatever chemical. When it comes to enema, you instill it and you expect the patient to go and what? Push it out. So that's enema. And you say that's active, isn't it? For washout,